right, are we good?
Yep, you're good. You're on.
We walked in and worked.
So we are very sorry we were a little bit late. So most of you who know me well, so I'm usually 15 minutes late for almost everything. So in this case, it was a little bit more than my own standard. So should be on time next time. Like the problem was we were still having, unfortunately, our kind of famous technical issues, and we were trying to have new platforms to make this better for how we are actually promoting this event. So that's kind of like part of the issue that we were having. So
I have to restart your camera, Kemal.
what's that?
We can't see you on your camera.
No. But I wasn't going to stop because of that. But if you want me to stop, so since now everyone knows that we are able to have these issues, we're good. So let's try. So I think it did something with the camera. So yes, if you're able to see the PowerPoint, we should be okay. Right? Are we okay on the Facebook side? So we're okay? All right. So I'll just go ahead, and then this time it's okay if you don't see me. So this is me anyway, so most of you know who I am. So our idea was, unfortunately, with some of the technical little issues, we want to make this right. So we didn't want to just share one PowerPoint and then no person, and then we didn't want to actually we wanted this to be a little bit more pleasant. But we'll get there, so we won't stop. My name is Kemal Erkan, and this is our recent update from United Medical ACO. We try to tailor this for our patients, so that we can actually reach out to our patients, and hopefully we can get to some patients to see what we are doing and how we are doing it differently. So today I'm going to go over some timelines here. So just explain to you what United Medical is, the latest updates on Corona, and one new topic that we have is surgery centers versus hospital cost discrepancies. And also today, our social worker from United Medical ACO, who's going to join me for the psychological effects of COVID-19. Jackie, actually, she's in the room with me. So now from United Medical side, every once in a while we get certain communication directly from United Medical for our clients who are not actually labeled as United Medical, but they are part of the United Medical network. So just to give you an example, what that may be is you may be getting the patient statement from CRIAS, Christiana Institute of Advanced Surgery, but because we do the business office services for them, and we also do the clinical, we are the clinical integration network, we are also we are directly communicating with the patients. So you may be getting a patient portal invite from us. And the reason we do this is because we do it on behalf of the client. So we want you to be taking advantage of those. So hopefully that is that is helping. So United Medical is more like the umbrella organization for all of our clients in Delaware. So while we are doing this, we also have contracts on behalf of our clients, so that we can actually get quality, less costs, and then better outcome for our patients. So we are one of the first in Delaware who got Medicare contract, and we are also contracted with Highmark Commercial and Health Options, MaryHealth, which is the Medicaid managed care in this case, and Humana, and also United Health dual plan patients. So we pretty much host all those different programs, different contracts on our platform on behalf of our clients. So when you hear our name, and then if you say that, well, this is not my doctor's office, we want to kind of fix that problem. So this is us reaching out to the patients by utilizing social media, and hopefully we can make some of the things more clear for you. Now, we also have some offices which belongs to United Medical directly. That's one of them is United Medical Clinic. In some, we have partial ownership. This would be American Surgery Center. And then some, we have a full executive service, and CRIAS, Christiana Institute of Advanced Surgery is the one. So we provide other services with PM and EMR software, medical billing, credentialing, IT support, application training, population health. We also support the system with different interfaces, with the available interfaces within LabCorp Quest, and which does actually help tremendously for our care coordination effort. So I do want to start with the daily updates. Now, the number, usually I go live here directly to the website, but I'll keep it here. So one thing that I want you to know is that we are putting these numbers side by side. So this is actually on the next meeting, we'll fix this. This 415 is what we had last April, where we were total number of cases being at 1 million. And May 15th, we went up to 1.476, 1,476,000. And then this was as of July 29th, but I can actually just pull the worldometer data, and that actually is something that we are getting all of our statistics, all of our numbers. If you have any, if you are not actually already doing it, you may want to do that. So this website, are you guys able to see the screen? Okay. I'm sharing now, not PowerPoint, but the page. Okay. So right now we are, as of today, it's at 5,431,000. Now, the way that I go through this, just looking at today, this is actually pretty much updated every hour. So it's about 15,000 is right now 12:31 p.m. Eastern time. So until midnight Eastern time, we are getting updates, and then they actually start posting the final number. Now, if you look at yesterday, you'll see that number being at 55,364. Now, you can, the reason actually, I mean, there are different websites actually, they are actually providing maybe the same information. Now, because this is more specific for our patients, when we look at today's numbers, one is that's really important for us is the number of tests. How we deal with this problem is not just as simple as what the percentage of total positive tests, but how many people we tested. And if you look at this guy here with the test in 1 million, and then if I look at this number with if I sort this by that, because again, this is for more focus on our ACO patients. So I'm gonna kind of maybe just look at the Delaware numbers closely. United Medical average on 1 million tests in 1 million is 207,000. So where we are from Delaware side is one about that, like 210. So we are pretty much a mediocre in this case. If the average is, I mean, you don't want to be average, you want to be better. Now, my example, and I'm hoping that our governor is watching this at some point, if not live, maybe while he's having a beer with stuff that he's posting on Twitter. I'm hoping that he will be getting this at some point. So this would be a good example and comparison size for us, Rhode Island. So because we are being compared to Rhode Island for almost everything else, how little we are, and that's another little state there, and then they're at 395,000 tests. That actually, more tests, more power to us, because then we'll be able to identify the issues in a better way, and we can actually see the accurate numbers. When we say accurate numbers, most people understand this a little bit differently. We are not saying that numbers are wrong. We are saying that numbers are not capturing everything. That means if once you test another 200,000 people, if the outcome is going to be different, what we have today is not accurate. So that's what we are talking about when we say it's not accurate. So from here, we'll go to our Delaware numbers. And Delaware, state of Delaware actually has specific numbers for the from their website directly. And I'm going to also open that from state of Delaware website. And it is, we are doing from the number of tests that we process, we are doing well. But again, if that number is not enough, then how much can we make out of that is a problem. So now why are we doing well? Because here is, you look at your 10-day running. So when you look at this graph here, you don't want to panic. The orange one is what's reported on that day. And then because state is very efficiently entering them every day, they really not. And then labs are not reporting them every day, and that's not happening either. So that's why that big discrepancy happens. So to kind of normalize this number, we look at the 10-day average, and 10-day average is the blue bar here. Now, if there is no big change on this 10-day average, changes on this orange line is not going to be as important. So now the 10-day average actually is now going up slightly, but it's still very little. So we are at 74.6. Now, this is also very important. So this is the total, the percentage of people who were positive from the ones who were tested. So the 10-day average, again, is 4.3. That number on Friday last week, it was 3.8. So now, we kind of, I mean, at least I kind of memorize these numbers because I do this type of presentation almost every other day. Now, these little changes, what if we had another, like, another 200,000 people tested? Would it be at the same level? That we don't have an answer. So that's why this whole testing issue is important. Now, today, one of the other things that I want to discuss with you guys is that the cost discrepancy between the cost gap between the healthcare providers. So when I wrote this article back in 2018, it's posted. You can find the full article on my LinkedIn profile or my personal website. So the way that I described this issue that time is because we have contract responsibilities with the outcome and the cost with the insurance companies and with Medicare, we wanted to look at our numbers very closely. Now, I do own a surgery center. Of course, I want surgery centers to be better. However, what we are discussing here is not about what we own, but it's about the real factual differences between the same service and how they are being paid. So the choice of what patient makes and the choice of what the primary care physician makes, the choice of your surgeon makes based on their availability and their block time in different facilities. Not everyone has access to the surgery centers, or they only have access to the hospitals in some cases, so they may not have a choice. So what we do from United Medical side is to make sure that we put these choices out there so then at the end of the day, it benefits the patients. So how is that going to benefit the patient? So I'm going to actually take you to this, this graph here. So when you get a simple gallbladder removal surgery, this is probably either second or the third most common procedures. Now, there are a couple ways to look at this. One is, in many cases, gallbladder is, we deal with the gallbladder in the emergency situations, which is a big problem by itself. So with our clinically integrated group, with the multidisciplinary approach that we have on the patient care, we want these things to be addressed earlier than before it becomes emergency. Now, that means if you have some unusual pain, then instead of just waiting for 2, 3, 4 weeks and then ending up in the ER, you may want to consult your primary care physician, and then they will send you a surgeon, refer you to a surgeon, and then you would be getting this timely care. So then you can actually make a choice. Now, what this means here is when you get the average number, these are based on Medicare numbers, Medicare allowable. So when you get a gallbladder surgery in the hospital, average is about $12,000. Now, Medicare patients pay 20% of this as either co-insurance or well, it's a co-insurance, but if you don't have a secondary, then you may end up paying that totally on your own. When that number is already so high, then 20% of that is going to be $2,400. Now, the same surgery and same surgeon can do this at an ambulatory surgery center, and then the payment from your insurance is going to be $2,000. Now, these numbers are real. So now the patient responsibility in this case is going to be only $400. Imagine paying only $400 after your insurance pays versus paying $2,400. And then knowing that our Medicare population has some financial challenges already, then for them to pick this up, it's going to be a big problem. So now, this is not just for Medicare, like at different level with the same type of gap. This is almost with every insurances. Now, of course, there are some procedures have to be done in the hospital setting, and our surgeons and our physicians are going to make that decision for you, and they will not take any risk. Not in our medical standards. We are not going to take any risk. Our licenses and in your life, we are not going to go through that. Of course, we want to make the right decision for you first, but this is how much the savings that we are talking about. Now, most patients don't know what this means. So our goal is to put this out there and then make sure that you can actually hopefully benefit from this. Now, today, our licensed social worker, Jackie Tomasati, is going to join me. So actually, I don't know if you are seeing me right now, but if you are not seeing me, you are not going to miss anything. So Jackie is going to sit on my chair here. Jackie, you are on.
Hi everyone, my name is Jackie Tomasati. I'm the licensed clinical social worker here at United Medical ACO. I'm going to talk to you today about the psychological effects that we have been experiencing with COVID-19. So some data that you're seeing right now on your screen is that Americans right now have been experiencing a real big increase with depression and anxiety, as well as there's been a huge increase in hospitalizations, as well as there's been a lot of phobia with going back to work, as well as people being within big crowds because, as you know, a lot of people are very nervous with the germs with COVID-19. There's also been a huge increase with substance abuse, as well as alcoholism as well. So we're seeing a huge increase of people who are relapsing. So a lot of people think that people are continuing to use substance abuse, but a lot of people aren't realizing that people who have been sober for 10 years, 20 years, 30 years, they are actually resulting back into their habits. And we're seeing a huge increase, unfortunately, with people that are dying. So that's been, unfortunately, something that we've been seeing. Something that that has been done is there was actually a recent study of the psychological effects that were done with COVID-19. There was a study that was actually done in March for the people that were sheltering in place back when COVID was really, really rampant. So about 47% of patients reported that they were having negative mental health effects from sheltering in place. A lot of patients reported that they were having a high impact of depression and anxiety due to sheltering in place. They reported a high impact of isolation, feeling tightness in their chest, and just feeling really out of place. Some people reported that they didn't mind it because, they felt as though they were safer. Other people felt that the isolation really triggered them. So this was an interesting study to see kind of how mental health patients really were affected by being isolated. Another study that was also done was also the effects of people who were losing their income. So this was also reported to see that 54% of people were having a negative impact as well. So a lot of people were also having a lot of impact because of, the massive increase of people that were losing their jobs because of COVID-19, which is still becoming an issue. A lot of this was also due to an issue with people losing their health insurance. A lot of people were having issues with not being able to pay for the medication that they were on. So a lot of people were unfortunately going back to the data of being hospitalized because of their mental health issues. That's where we saw a huge increase because people weren't able to afford their medication anymore. People were having to go into hospitals because they weren't able to afford their medication. So this study really tied into a lot of different impacts because of the job loss. Another study that was also done was to see the different socioeconomic classes and how they were affected due to their mental health. So as you could see, the lower socioeconomic class was greatly affected because of the risk that they pose with the Medicare and Medicaid population, as Kemal was talking about earlier. They were greatly affected, especially in that mental health region because of the mental health side effects with everything going on with COVID-19. So 50% of them were definitely reported at least being affected in their household. So that was definitely something that at least in that time of March, and I would be interested to see now for the studies that are already being done and the data coming out now, how the psychological effects are definitely being affected with that currently. Something else that was also being reported was people who are having comorbidities and how the negative effects have also impacted their mental health. So if you're having things such as hypertension, diabetes, COPD, things like that, and how they're also impacting their mental health. A lot of people were staying in their house. A lot of people were, eating unhealthy. A lot of people were not seeing their primary care physician. They weren't going to see their heart doctors. A lot of people were neglecting a lot of their medical needs because they were afraid. They were afraid to come out. So it really impacted them medically. It impacted them. It impacted their mental health. So a lot of them, as you can see through the study here, it really impacted all of their health in general, not just the psychological effects, but in general, their mental health and their physical health all together. So in conclusion, the behavioral health with the psychological effects of COVID-19, it really impacted us completely. The behavioral health aspect of COVID-19 is really greatly affected. The suicidality of COVID-19 is really risen. So if you or a friend or a family member is suffering, please make sure that you do reach out to them during this time because the numbers have risen. Substance abuse has absolutely risen. So please make sure you reach out to your local crisis line. There are hotline numbers. Please don't be afraid to reach out to us if you need help with any of those resources. Please continue to go to your primary care physicians, your behavioral health specialists. Behavioral health integration is really key to success for all of us at this time.
Well, thank you so much, Jackie. We have a couple questions, and I believe some of them are related to your topic. And I'm going to actually stop sharing the PowerPoint. And then, Tanner, how do I bring the...
Should be press stop share. press stop sharing the screen here, and it should bring up your webcam. There's a little bit of delay, so I'm not sure. It looks like we're good. No, it should be you guys.
So now we are not doing social distancing. Okay, so here is, we'll add some here. Okay, we can have, you can see me and Jackie. Earlier what we were trying to do was if we could actually do this with the Zoom and then she would be in her room. So there are some interface issues. So we actually got 4 times disconnected. So, but then we still wanted to do it anyway. Now I see some questions for Jackie, and then I'm gonna ask those on your behalf. I think Tanner, it was on your side that I saw them.
Sure. Yeah, so Jackie, question for you. Question is, how does the use of behavioral health assessments help PCPs better manage their patients?
So that answer is, I'll swing into the camera, my mask. So that answer is the behavioral health assessments really do help PCPs assess behavioral health patients to gauge exactly where they are in that behavioral health realm. So there are certain types of assessments. There is a substance abuse assessment called the SBIRT. There's a anxiety assessment called the GAD-7. There is a depression assessment called the PHQ-9. And then there's a whole new assessment that came out per the state of Delaware called the well-being assessment. But that assessment, each assessment scores a different number. So if I'm going to use the PHQ-9 for an example, if Kemal comes into the office and he's experiencing some depression and he scores as high as a 17, it really ranges that Kemal has a really scary range of depression. So the PCP at that point would, raise the red flag and say, hey, Kemal, you have a really unhealthy rate of depression. I think you should see our social worker, Jackie. I think you need to, see a therapist at this point. I think, your depression at this point is taking over. At that point, it would be a really unhealthy rate. If he scores a 5, it's not as an unhealthy rate, if that makes sense. At that point, the depression wouldn't be as severe as if he had scored a 17. So the assessments are really, really key because it helps you range what score it is to really manage to see how severe the depression is. So that's why the assessments really are key, because it also helps us manage to see, especially if the PCP is managing the medication, to see if the medication's working. Because if we are prescribing, let's use Prozac for example, if we prescribe Prozac for Kemal and he comes back and says, I'm still scoring, if he still scores 17, it's not working. If he comes back and now scores a 5, clearly it did work. So it's really, really key that we use those assessments.
So that was kind of like my punishment. So bringing you here for the presentation. So then
So he's my guinea pig, he's my example.
Yes, you use me as the patient example. But well, thank you for the answer. So I have a couple other questions that I think they were for me, so I'm going to answer those.
Scoot out.
Jackie, thank you so much again
No
for
problem.
joining us. So some of these items and presentations, we are actually doing that at our provider meeting. So we want to make sure that patients also are familiar with these. So one of the questions is it required for a surgeon to be in the UM-ACO to perform surgery at ASC? So we have some surgeons, this is for our American Surgery Center, we have some surgeons who are not part of the ACO, they still have time there, and that's not a requirement. Ideally, we want to actually, personally, I believe that ASCs are the integral part of the cost savings, and the ACOs, accountable care organizations, they have to have a partnership with the ASCs so that they can actually take care of the patient in a timely manner, and then it can be done in a less expensive setting. Now, not every ASC, well, again, I have a horse in the race, so, but I'm allowed to be biased. This is my presentation, so I'm not doing this for the government. So let's just talk about what I mean by that. So we are when we actually took American Surgery Center over. This was back in 2015. The idea of the surgery center was, or the way that they were operating was, that it's just like any less fast-paced cases could be done, nothing complicated. So then nurses, if they were kind of like at the retirement age and they want to slow down, they would just work for the surgery centers. And then the staffing schedule model would be not permanent employees, but they would be all like as needed. And it created a lot of issues. So we changed that entire model, and all of our nurses are full-time or permanently working for us. So then there are no changes from one day to the next. They're all experienced in all the surgeries that we are taking care of. As you know, your experience and your knowledge only gets better when you do more of the same thing, and then with the good supervision, of course. So, and that's what we have in our surgery center. So I cannot say that for every surgery center. Now, of course, I said in the beginning that we are biased, but there are some non-biased ways to certify what I'm saying. Our surgery center is one of the 15 surgery centers in the United States that has the MBSA QIP certification for Bariatric Center of Excellence. And then we are also one of the limited surgery centers out there with the Blue Cross distinction recognition. And then we have the same quality recognition for Aetna insurance. So as you can see, like there are already certifications validating what we have, what I'm saying, and it's not just like I'm bragging about how great we are, but it's a different topic for a different day. So I think another question was, why do I care what my insurance pays? So, well, in the last 10 years, one of the biggest issues with the insurances, you have your monthly payments, and what you see from the insurance side is there are high deductibles, high co-pays, high co-insurances. So the patient responsibility of the total cost increased in the last 10 years. So I'm going to give you a real example without the name of the insurances. When I started United Medical in November 2005, that was almost 15 years ago. So I was able to provide full coverage for our employees because it was the cost was at certain number. Now that number is about 2.5 times higher today for the similar population. So the cost of what we have for the medical insurance from the employer side went up by almost 2.5 times. So if you were paying $100, it is now $250. If you were paying $500, it is now $1,250. So, and then what did we end up doing is we actually reflect some of the cost increases to the employees. So now we are not able to cover the entire thing because our business, the profit didn't change or it didn't increase because insurances are not paying more for the primary care or the specialist. They are paying the same amount that they were paying 15 years ago. So these are all public numbers. So that's why I'm comfortable telling you this. But that's why you would care because you are actually paying the extra cost. I would say. I'm gonna check if there are any other questions.
You do have one more question, Kemal. And the question is, why is the surgery center more cost effective for a patient?
Well, part of it is with the fee schedules being set up by the insurances. So they don't pay us more. So if for the same procedure, like Medicare, as I was sharing earlier, Medicare fee schedule, allowed fee schedule is 5 times higher than what they pay for the ASC, because the idea in the beginning, I guess maybe 25 to 30 years ago, the idea was only certain things were going to be done in the ASC setting, but that changed in the last several years. Now, in the last 5 years, it changed even more drastically, because we are doing gastric bypass, gastric sleeve at the surgery center. 2 years ago, we were not doing it. Today, we do more than 300 cases a year. So, and then our nurses, the experience of the nurses changed. So then everything else that we are doing for the center is now more. But that fee schedule allows those cases to be in a less expensive setting. Now, the other thing is that this is important. In the surgery center, we can have patients overnight. We do have that license. However, almost 100% of our patients were discharged by 11 p.m. in the last 12 months. So this is a fact. So we didn't have to keep anyone. Now, in the hospital, every time you have a procedure, if there is no big push from the insurance, then usually patients are forced to stay for overnight, and then one more day, then if there's not enough resources, then they end up spending more, because then as you stay in the hospital more, then those things are being charged on top of your surgical fees. So that's why it would be important. Other questions?
I do not see any more.
Now we are going to post the video later on. You can actually watch the PowerPoint. Now I will try to promise you next time we'll be on time. So we'll do some more testing. To see if we can actually get things. We did. I mean, it's not like this time. It was definitely. I have screenshots I can share with you later on. So it is the interface between the Zoom and the Facebook didn't work out. So, but our goal is not anything other than reaching out to the patients. By doing this, I'm not making more money, or Tanner or Jackie are not doing more money. We want to reach out to you. We want this to be available to you. So if I'm late, but what I'm providing is important, so I hope you don't mind for now. I mean, I could give you a lot of garbage and then be on time, and then that means nothing, right? So, but still, I'll be on time next time. So we are gonna stop here for this week, and I personally do enjoy these events. From our structure standpoint, I want these things to become part of our business culture, so that more of our executive directors can actually take these types of do these types of events, because I think the biggest issue is not having direct access to the public. This was an issue 20 years ago or 10 years ago. Today we can actually just turn our camera on, and then we can start a live event, and it is an extremely important part of what we do, and so we have no excuse not to reach out, and that's why we are doing this. Now, lastly, there will be 3 events next week. We did also 3 events this week. Dr. Irgau from Christiana Institute of Advanced Surgery from CRIAS and American Surgery Center, he will be doing his Facebook Live event on Tuesday at 7 p.m. And also, I believe Dr. Gail Wynn from CRIAS is going to do a webinar, GoToWebinar for the weight loss surgeries Thursday at 7 p.m. And We also have a couple support groups started. So next week, I will start introducing those to you and then access to those. And then we'll start sending those links to them, to the patients, so you can actually have full access to what we are doing. Hopefully this was beneficial for you, and thank you for watching us, and we'll see you next week. Bye-bye.